you guys should have listened to the videos that were posted on your Canvas pages that went over neuroanatomy and neuroassessment. I'm going to actually be reintroducing some of those topics, but I'm going to do it in case study format so that you can apply the information to different scenarios. Some of the case studies go a little bit in depth, but we're going to break it down so that you guys can just look at the differences in assessment, and basically you can look at how you're going to go about taking care of a patient who comes in with these kinds of symptoms, okay? And look at the assessment findings and interpreting these assessment findings. So we're going to get started. I'm going to start the slideshow. If you have a question, please just stop me, raise your hand. If you want to type something, type it. Dr. Albuja will be monitoring that, and she will interrupt me from time to time just to let me know who has a question or who wants to speak. There are a lot of questions on the case studies. So if you feel like you know the answer and you want to jump in, please unmute and do so. I want this to be as interactive as possible. Circumstances doesn't allow it to be as much, but we're going to try our best to just make it as interactive and as much of a good learning environment as we can possibly do. So we're going to start with the first case study. Jen is a 55-year-old female brought into your clinic by her husband with difficulty with speech. According to the couple, Jen has been forgetting the name of familiar objects, often gets stuck during a conversation. Sometimes she can get the word out after pausing and making extra effort, but most occasions she gets frustrated and shuts down. She explains that she knows what she wants to say and she understands everything that is being said to her. She just can't seem to find the words to answer sometimes. Okay, so in your video, I went over lobes of the brain, and we broke down for you which lobe controls what, kind of also broke down for you where different centers in the brain that controls integral functions are located. Now, Jen is having difficulty with speech. And if you read the scenario, you'll see that she's having difficulty with speech production. She is not necessarily having difficulty with understanding. She's having difficulty with production. Now, I know in my video I say my Broca's area is firing at 100,000 times per minute. Your Wernicke's area is firing at 100,000 times per minute. If you're listening and paying attention to me. Broca's area, it's located in your frontal lobe. And it depends on if you are left-handed or right-handed. All right-handed people are left brain dominant. Now, there's a minute percentage of the population of left-handed people that are right brain dominant. And when we say right and left brain dominant, that depends on where the speech center is located, because that's how you really deduce which part of the brain is dominant and which is not. You deduce it by the speech center. Your speech center is always located in your dominant hemisphere. And for most of us, that is our right hemisphere, whether you're left-handed or right-handed. There's a minute percentage of the population that has a dominant right hemisphere. And those people are left-handed, and it's about maybe 10% of left-handed people have a dominant right hemisphere. Only that amount. The rest of them have a dominant left hemisphere. Now, Jen, we want to ask questions like, is she left-handed or is she right-handed? We also want to ask questions like, okay, when did this start? That is very important, especially because Jen is coming in with speech difficulty. Did it start yesterday? Did it start today? Is it something that's progressive? Because that will kind of get us into the idea of starting to think of what's going on with Jen. Is Jen having a stroke? Does Jen have a brain tumor? Does Jen have something that's actually affecting that part of the lobe that's been slow and progressive? Or is it acute onset? This is what we need to figure out so we know exactly how to deal with Jen. Okay? So she's having difficulty with speech production. With speech production, we know that it is broker's speech that's affected. Broker's speech is your expressive speech, is your motor speech, okay? And your motor center is in your frontal lobe, okay? Your sensory center is in your parietal temporal lobe, which is your Wernicke's. So you have Broca's and Wernicke's. Broca's expressive, Wernicke's receptive, okay? Understanding. So from her description, she's having difficulty expressing, not understanding. So when we ask which area of the brain is being affected, it's probably frontal. And if she's right-handed, it's definitely left frontal. Okay?
Dr. Morton, I'm sorry to bother you, but there's still some people without their mics muted, and there's a lot of background noise. Can you guys please make sure you mute yourselves? Thanks so much. Sorry, go ahead.
No worries. Let me pick up where I was. I can't remember where that was. Anyways, so again,
frontal, I think you were talking about the frontal lobe.
I got it. So your motor speech again, frontal lobe, okay? Your receptive or your understanding of speech your receptive speech is located in your temporal lobe, which is your Wernicke's speech, okay? So the questions we want to ask, when did it start? Okay, is this slow and progressive or is this an acute onset? Okay, we want to ask, is she right-handed or left-handed? Because then we're trying to deduce which part of the brain is being affected. Okay, and these will help us with our differential diagnosis in the future when we're doing. But now we have to figure out how we're going to assess her. Okay, so we're going to do a history with the questions. What are the most important questions for you to ask the couple at this time? Again, did it just start today or has it been progressive? And if they tell you this is an acute onset, you want to know the exact time of onset. That is very important in the history, okay? What are the pertinent questions? Okay, well, they tell you that this started like 3 days ago. You want to know, is she a cancer patient? Does she have any malignancies? Because then you're thinking, metastasis. How do you work that out? Okay. What are the initial tests that you would order for this patient? Well, if they tell you it's an acute onset, or they tell you that it's been going on for a while, the fastest test that you can possibly do in this patient is a CT scan of the brain. CT looks good for blood, okay, and it will show you abnormalities. It doesn't look well at tissue. So if there's a stroke, or if there's a brain tumor, you're going to have to order an MRI, which is more sensitive with tissue. However, initially, when someone comes in like this, you always want to rule out blood, okay? So this is where you're going to say, well, I'm going to get a CT of the brain. Other pertinent questions. Did she have any head trauma, okay? A head trauma could actually give you a intraparenchymal hemorrhage, a subdural hematoma, epidural hematoma, and all of these can give you an acute change in neurological status. So you have to find out from her if she had any head trauma, was she in a car accident recently, does she have any history of malignancies, okay? And you also want to know vascular risk factors. If there was an acute onset, it could be a TIA. It could resolve in a little short time after that. So you want to know, does she have hypertension? Does she have diabetes? Any vascular risk factors that can put her at risk for a stroke, okay? Again, the initial test we want to do, we always want to rule out blood first because that is an acute phenomenon that she may need surgery. So you want to make sure that there's no blood. So you're going to order a stat CT of the brain to check this out, okay? If your diagnostic test shows stroke or tumor, what part of the brain would you say is affected and why? We just went through talking about where Broca's area is. We said that this is expressive speech and Broca's area is located in the frontal lobe. And for most people, if she's right-handed, it's left. If she's left-handed, then It's hard to tell. We'd have to look at other symptoms. So if she's left-handed and she has weakness on the right side of the body, then you're going, okay, well, if weakness is on the right side, then it's the left brain. So she's having speech difficulty and right-sided weakness, we know it's the left brain. But if she's having speech difficulty and left-sided weakness, then you're going, okay, so if you're having speech difficulty and left-sided weakness, if your left side is weak, then it's your right side of the brain that's being affected. So therefore, her speech center may be in her right brain. And that is how you're going to tell if she's left brain dominant versus right brain dominant. Now, if by any chance that she has no other symptoms, you have to wait for the imaging. Okay? Doing a neurological assessment, it is so, so important that you understand the basics of your anatomy, because if you don't, you can misdiagnose someone. If you do, it's easy for you to start saying, okay, where in the brain, what's going on here, and you can actually deduce and you can actually come up with pathology for what's going on with the patient without even scanning them, okay? So you really have to have a basic understanding. When you're dealing with neurologically ill patients, you should have a basic understanding of neuroanatomy. It actually helps, okay? Do you have enough information to formulate a diagnosis? No, you really don't, okay? Other things too that you want to consider. Has she had fevers? Okay. Has she had issues with nausea, vomiting? Because if she's had fevers, then you could have an infection. You can definitely have a brain abscess. Does she have a sinusitis? Does she have an otitis media? I always tell students all of this is connected. Okay? So if she had a bad sinusitis and she comes in now with speech difficulty, or she comes in now with headaches, she can definitely have an abscess in her brain. That's on that side of the brain. Okay? Does anybody have any questions on case 1?
That's why every 6 months you're having this problem. So until
anybody?
let me see if it's
We're hearing background noises still, guys.
you did not.
All right.
Dr. Morton, everyone's giving some good ideas here in the chat box about different symptoms and stuff. Do you want me to tell you or just?
Yes, please. Tell the rest of the class. I can't see it.
Okay, you can't see it. Okay, yeah, no, they should be able to. If you guys check out the chat, that's, people are putting ideas, actually, a question is, would abscess be shown on CT?
Actually, the abscess will not be shown on CT. It will show that there's an area of hypodensity, which could mean a lot of different things. It could be a stroke. It could mean an abscess. It could mean a tumor. It is very hard to tell. Okay, so I can't tell you for sure that an abscess you can't say it's not an abscess. All you can say is that there's an area of hypodensity that you need to evaluate further. Remember, CT, great to look at blood, great to look at bone, not so great to look at tissue. So if there's an acute tissue, something going on, you will need an MRI of the brain. So that is where you're going to move to next. Any other questions I missed, Laura?
I don't see.
Contrast would make a difference.
Oh, there it is. Yeah.
Contrast can highlight the area, and it can show up as a stroke. It can show up as a tumor with contrast. The problem with iodine, with CT contrast, it's iodine, and iodine is very nephrotoxic. So instead of putting them through that, it's better to do an MRI. An MRI actually is perfect to look at brain, at tissue. An ultrasound will not show an abscess. Okay. We don't really use ultrasounds on adults, especially in the brain. We use them on the pediatric neonatal population, but not so much adults. Anyone else? Did I miss anything else, Laura?
I don't see anything else. I think that's it.
I forgot about the brain part. What is it? Oh, no worries. No worries. Okay, let me go back. I have to hide the chat box again because I can't see the rest of the scenario. Okay. So case number 2. John is a 57-year-old right-handed male brought into the emergency room via emergency medical services for an acute onset of weakness and sensory loss over the left side of his body. Immediately, you're thinking the left side of his body is controlled by the right side of the brain, okay? So you're knowing at this point something is going on in his right brain. He's able to move the right side without difficulty, but denies sensational pain or temperature on the left. Additionally, when presented with his own left hand, he denies that it is his. He will not respond to you unless you're standing on his right side. You suspect that he had a stroke, which is confirmed on imaging. Which area of the brain would likely cause John's symptoms? Okay, so when we did the neuroanatomy on your video, we talked about the parietal lobe. And the parietal lobe is our sensory lobe. So it actually tells us where we are in space and time. It's good for sensory integration. So when you have someone who is having sensory loss, okay, you, especially when they have pain and temperature, they can't discern pain and temperature sensations, you want to start thinking parietal lobe. Because remember, all the sensory input from the body goes into the brain, goes up through the spinal cord, in through the thalamus, and then to the parietal lobe for sensory integration. The back of the frontal lobe is the motor cortex. The front of the parietal lobe is the sensory cortex. Okay, so motor cortex, frontal, sensory cortex, parietal. The parietal lobe is more like a sensory integration lobe. Okay, so he's having difficulty with pain and temperature sensation on the left side of his body, and he has something that we call, when we put his hand in front of his face, he is unable to identify it. That's actually called neglect. Okay. When he is neglecting one side of his body, you're going, okay, he cannot discern his own hand. When someone's doing that, you want to think about right parietal. Okay? Right parietal is the lobe that's actually giving you those symptoms. Okay? There's another word for it, and why is it not coming to me at this moment in time? But it'll come to me in a few minutes. You neglect, you can't identify your own body in space and time. And for some strange reason, I can't remember the word right now, but it'll come to me in a few minutes and I'll tell you. So he's not able to identify pain and temperature on the left side of his body. Anytime you see that, where you can't discern the left side of your body, they can't tell where they are in space and time, think right parietal. Okay, think that something is going on in their right parietal lobe. And these patients are at high risk for hurting themselves. One, because they don't realize that the left side of their body doesn't work. They have no perception of it. So they would try to get up, and then that side of the body doesn't work, and they would fall and hurt themselves. So one of the main things that you want to monitor for these patients is safety. They can really do some real bad damage. And actually, that was a question on one of my neuro boards. They always ask that question. Right parietal injury, patients are at high risk for danger of hurting themselves because of the fact that they do not understand what's going on with that left side of the body. Okay. All right. Any questions there, guys?
Someone asked about visual field agnosia.
No. Agnosia is, remember, your vision is in your occipital lobe. Okay. So you're not going to have any visual issues from your parietal lobe. Okay. Agnosia is the ability to, let's say I have this, I don't know if you can see it, this cap in my hand. Agnosia is the ability to recognize common objects. I see somebody is asking about agnosia there. That's why I'm saying that. If I put something in your hand without you looking at it, you're supposed to be able to identify it. Okay? Your inability to do that is called agnosia. So nausea is the ability to recognize familiar objects. If I put a key in your hand, if I put a pencil in your hand, you're supposed to be able to take that key or that pencil and recognize what it is. The inability to do that is agnosia. And yes, that comes from your right parietal also. Praxia. Praxia is the ability to perform known tasks or living tasks. If you are unable to do that, you become apraxic. Okay? And again, that also comes, praxia is more frontal lobe. Nausea is your parietal lobe.
We have a couple questions too. Autopagnosia and prosopagnosia. Sorry, I didn't hard time with that.
Autopagnosia is really that writing in the arm. If I write something in your hand, you should be able to identify it. The protoprognosia, I don't know what that is. I've never seen that before. So you can identify that. If you can define that, that would be great. Okay. We have agraphia, agraphia. Agraphia is basically if I write the letter E in your arm or your hand, you should be able to identify it without looking at it. Okay. Agraphia is the ability to do that. So that's another one. What else?
The prosopagnosia is inability to recognize familiar faces.
Oh yeah. Photoprognosia, she means.
That's what I'm guessing.
How do you say it? Come back down. I can't see that question. Your nosias, again, you have visual, you have auditory agnosia, you have visual agnosia, you have sensory agnosia. Your visual agnosia is basically your occipital lobe not being able to interpret what it is. Your parietal agnosia is basically so those are the different types of agnosias. Okay.
Someone asked, what is the term of the neglect?
I can't remember. Is there hemibody neglect? There is another word for when you can't recognize it, but I can't remember that word is. Hemianopsia comes from the parietal, the occipital lobe. Extinction. Oh, Jennifer, yes, that's what it is.
Ah.
I could not remember that word. Is extinction. So when you're not able to recognize one side of your body, it's called extinction. All right. And for some strange reason, I couldn't remember extinction.
Guys, someone
there?
still has their mic on and we can hear you turning your pages.
It's Yarizette.
I think it's Yerazette, not to call you out, but I can hear you turning the pages. Can you just mic mute your mic, please? Thanks.
They've been
Is everybody
freaking
good?
telling you that for the last 20 minutes.
All right, closing that. All right. Jane is a 53-year-old woman, presents with complaints of vision loss after an auto accident, where she pulled out in front of her car approaching from the left side that she claims she never saw. On complete visual field exam, you find that the woman has a left homogeneous hemianopsia. You perform an MRI and you find a stroke affecting part of her visual field. Based on her visual field defect, which of the following is the most likely location of her stroke? Now, when we talked about the occipital, we had the right occipital lobe and the left occipital lobe. And in your HEENT lecture, you should have gone over a little bit of your visual fields and what your visual fields are and which conditions will give you which visual field neglect or which visual field would be affected by what. So remember that you have your right visual field is completely on the right. It's one visual field. So it's not one eye. When you're doing your visual fields, you're doing confrontation. You're checking the visual fields on the right side and you're checking the visual fields on the left side. Okay? So your right visual fields is half of this eye and half of the other eye, everything to the right. The left visual field is half of this eye and half of this eye, everything towards the left. A homogeneous hemianopsia means that that entire visual field is gone. We have also quadranopsias, which means a quarter of that visual field is gone. And we have bitemporal hemianopsia, which means that the outer visual fields on the temporal sides are gone. Now, when we discussed HEENT, we talked about pituitary adenomas. Pituitary adenomas, because the pituitary gland sits in your sella turcica, which sits right below the optic chiasm. So when that pituitary adenoma grows, it actually compresses the optic chiasm. When it compresses the optic chiasm, you get that bitemporal hemianopsia. If someone has bitemporal hemianopsia, you're not thinking stroke. Not that it can't be, but usually it's not. You're thinking bitemporal hemianopsia, that's probably not a stroke. That's probably a pituitary adenoma. Homogeneous hemianopsia means that the entire visual field on the right or the entire visual field on the left is gone. And that usually indicates that there's something in the occipital lobe. So whether there's a tumor, whether there's an abscess, whether there's a stroke, it is in the occipital lobe. If I have a left homogeneous hemianopsia, I have a lesion in my right occipital lobe. If I have a right homogeneous hemianopsia, I have a lesion in my left occipital lobe, okay? So when you're looking at homogeneous hemianopsia, it depends on where it is. And usually, if that's happening, it's a lesion of the occipital lobe, okay? Now, we have right occipital lobe here as one of the answer choices. You have a car approaching from the left, and usually this is how people know that they've lost a visual field, because they'll tell you that there's no way, I didn't even see that car coming. They had no perception of that car coming, and that car comes and slams onto them, okay? So if that person was approaching from the left and they didn't see the car, that means that they have a left visual field cut, or left visual field neglect, or a left homogeneous hemianopsia. Now, strokes can give you quadranopsias also. It could be half of the visual field that's gone, or a tumor, depending on where in the occipital lobe it sits. So it can be a left homogeneous hemianopsia, a right homogeneous hemianopsia, or quadranopsia. Those are associated with strokes or tumors. But if we're thinking about a temporal hemianopsia, we're thinking something in the optic chiasm or some kind of issue with the optic chiasm. So you have a tumor growing or a macroadenoma from the pituitary gland, or you can actually have a hemorrhagic a hemorrhage into the pituitary gland that can actually give you issues like that. So you want to think about those things. If it's a bitemporal, they've lost visual fields on both sides of the temporal areas, then you're thinking, okay, this is something with the pituitary gland. If they've lost half of their visual fields, you're thinking occipital lobe. Quadranopsias sometimes can be your occipital lobe stroke, or depending on what's going on, it could be that they have a macroadenoma that's only pressing on one side, and it's actually cutting off some visual on one side, and that's why you're seeing a quadranopsia. But textbook, a bitemporal hemianopsia, pituitary, homogeneous hemianopsia, or quadranopsia, you're thinking occipital lobe. Okay?
Is this condition reversible?
Which condition?
The
homogeneous hemianopsia?
Yes, I'm believing that's it.
If the stroke, remember, when we talked about neuroanatomy, When you lose neurons, when neurons die, they do not come back alive. Okay? Most of the times, there's a little bit of swelling after a stroke. So when that swelling reduces, then some of the vision may come back. But a lot of times people have to live with these. There's a lot of therapies that they do, occupational therapy, where they teach them to drive with these neglects. It is very difficult. A lot of these people have to actually get these types of training before their license can be reissued. Okay? Because if they have it documented in a medical record that they have a anomalous hemianopsia and they did not go through the proper channels and then they get into another accident, they can be held liable. Okay? So usually they go to rehab, they work with the occupational therapist. In Baptist rehab or in the rehab center, they actually have simulated driving that they put the patients through these simulated tests to actually give them back their license if they can pass. But most of the times, if it's a stroke, usually this do not come back. It may improve, but to regain it completely back, sometimes that doesn't happen. Any other questions? And you guys remember how to do your confrontation testing. I'm gonna use my niece as a guinea pig so that I can do the demonstration on her. Julianne, she's supposed to be close. Come on, hurry. Sit right there. Hi guys, say thanks Julie for being my guinea pig. All right. So when you're doing your confrontation test, remember you're standing in front of the patient and you're going to check the visual fields in both visual fields. Now, grossly, you do not have to tell the patient to cover their eyes. Grossly, you can do it without them covering. So you're going to stand a distance away and remember that you're checking your visual fields against theirs. So if you're not seeing your hand, they can't see your hand. If you're asking them to count fingers and you can't see the fingers, then they won't be able to see it either.
Dr. Morton, can you move your camera down a little bit?
I'm sorry?
Can you move your camera down a little bit? We can't see her very well. Awesome. Perfect. Thank you.
See her now?
We're good. Thank you.
Is that better?
That's even better. Perfect.
Yeah, I think there was a light from the window. All right. So I'm standing here and I'm going to ask her to look at my nose. Don't move your eyes. Don't move your head. Just look straight at my nose and tell me how many fingers do you see. Now. 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 Now, you see I'm going through both visual fields. I didn't just check one eye and that's it. I have to make sure that I check on both sides. Now, let's say I had asked Julie to do that, and I noticed that when I put my hands this way, she didn't see them. Now I'm going to say, take your left hand and cover your left eye for me. Okay? And I'm going to do the same. And I'm going to tell you, look straight at my nose. Don't move your eyes. Don't move your head. How many fingers? Now. 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 Okay. And I'm going to have her do it on the other side the same way. Okay. I know a lot of you do the thing where you do, tell me if you see my fingers. Tell me if you see my fingers. Again, it's not resourceful if you pull your fingers all the way in front of the patient and then say, tell me if you see. So you want to make sure that you're wiggling your fingers at a safe distance so that they can see. Okay? If you're doing, tell me if you see my fingers, you want to bring your fingers in slowly so they can identify when your fingers are there. Anybody have any questions on that? Anything,
Okay.
Laura?
Yeah, a couple of questions. Is there any way to have you on the big screen when we do that? And do we not cover the right eye as someone's asking?
What do you mean?
I'm not sure, but I think that you grossly you keep them uncovered, and then if you need
you're gonna have to
that,
cover both eyes.
Right.
I just demonstrated one, but yes, grossly you're gonna do without covering, and then when you're testing, You're going to cover both eye individually.
Perfect. Okay. I'm hoping
Any other
that covers. Yep. She's got it. That's perfect.
All right. You're done. I'll call you if I need you again. All right, guys. So we're going to move on. So the answer was
A.
A, B, C, D, E. Are we getting the answers, Laura?
Yes, I'm getting a lot of A's.
Okay, beautiful. Yes.
Yep. All A's.
Right. A is the answer. All right. Great participation, guys. I love it. See, we're nurses. We can improvise. Case number 3. 56-year-old Taiwanese female presented to the emergency room of your hospital with acute onset right upper lid ptosis. Okay? Noticed since 4 days ago. The patient reported that the right upper lid ptosis was with a progressive course, while no diurnal changes was noted. Okay. If you say that there are no changes throughout the day, that is very important. I want you guys to just note that she says that she has this ptosis, but it doesn't change as the day goes by. Okay? Those are things that is a pertinent, very pertinent negative that you need to really take a hold of. The patient denied diplopia, meaning diplopia means that I don't see two things, okay? If it's 2 fingers, I don't see 2 fingers, I don't see 2 people, okay? She denies any blurred vision, denies any eye pain, denies any headache, denies any focal numbness or weakness. The patient also denies recent head trauma, prodromal symptoms suggestive of viral illness. Other medical problems includes diabetes, mellitus, type 2, without appropriate control, and diabetic nephropathy. Her usual medications before admission included short-acting insulin 3 times a day and long-acting insulin, but her compliance was poor. She never drinks or smoked. The brain CT performed in the emergency room showed no intracranial lesions. Now, how are you going to assess this patient? It's very important for you to do a complete neurological exam, but you have to do a really good history on her. Okay? What things give you ptosis? There are a lot of things that can give you ptosis. A lot of neurological issues can give you ptosis. A stroke can give you ptosis. What is ptosis, by the way? Okay? What is ptosis? Somebody turn on their mic and tell me what ptosis is. Come on, guys, not all at once.
An eyelid drooping?
Eyelid drooping, yes, it is. Which cranial nerve controls the eyelid? Which cranial nerve opens the eyes?
7. Oh no, 3.
3. Cranial nerve 7 closes the eye. Cranial nerve 3 opens the eye. So if I have a lid drooping, is that 7 or 3? Is that a deficit in 7 or 3?
In 3.
That is 3. Yes, because that means that they can't open the eye. That's why the eyelid is drooping. So if you have a ptosis, you know that there's something going on with cranial nerve 3. Now, important things you want to know: is there a brain tumor? Is there a stroke going on? Okay, but there are a lot of other things that can give you ptosis too. Okay, that you want to take note of. So you want to ask her, has she traveled outside of the country? Why is it important to know that? Because there are some viral illnesses that can give you issues that can give you a ptosis. Okay, what else do you want to ask? Why was it important to know that there was no change throughout the day? Why was that important?
Because it's not myasthenia gravis.
Well, it could not be it probably isn't myasthenia gravis, because myasthenia gravis, when you rest, it actually resolves. So they wake up bright in the morning, and then at night, as the day goes by, then their lid starts drooping as we progressively get further in the day. Okay. Diplopia. She has no vision issues. It's just dystosis. Okay. So, is it an MS? Probably not. Is it a stroke? It's like, okay, well, it's a partial third nerve. And you'll hear neurologists say that a lot. Oh, they have a partial third nerve. That means it's only affecting some of the functions of the cranial nerve number 3. Okay? Not all of them. Okay? Let's see if she has anything else going on.
Dr. Morton, someone wanted to ask if we should do a Tensilin test.
Well, you can do a Tensilon test, and a Tensilon test is actually to rule out myasthenia gravis. So if you want to just use that and say, well, you know what, this is probably not myasthenia gravis, then yes, you can do a Tensilon test. And in most cases, they probably would do it just to say, well, you know what, this is not myasthenia gravis. A lot of times, though, neurologists are hesitant to do a Tensilon test because what you're doing is you're giving this person, you're like giving their parasympathetic nervous system a boost when you give them this Tensilon, okay? Because it is a cholinergic drug. So what could happen is you can stop that person's heart. That's why when they're doing a Tensilon test, if you've ever seen it done at the bedside, you always have to have atropine there at the bedside, because if you slow that person's heart down tremendously, you have to give them the atropine to bring it back up. Remember, your cholinergic system says slow, your sympathetic nervous system says speed up. So if I'm going to give a cholinergic drug, I'm going to actually enhance the parasympathetic nervous system, and I'm going to enhance all the issues that the parasympathetic nervous system can do. So most neurologists, if they can help it, they won't do a Tensilon test. They do it if they are like trying to rule it out really quick, if the person has no other medical issues. And they do it a lot of times more in the office setting, but they have to have them hook up to a 12 lead. They have to have atropine right there, and they have to be able to administer it if anything happens. Okay, it can become a code situation really quickly. So yes, you can do a Tensilon test. Any other questions? What laboratory tests are pertinent for this patient?
Sorry, someone else had a question real quick. So it could be a palsy of nerve 3 brought on by a virus. Maybe she went home to Taiwan.
Could be. The viruses that come to mind are like herpes simplex virus, Lyme disease. Okay, so yes, it could be a virus. So you want to check, you want to do a viral load. You want to do like a Lyme titer. You want to do a herpes simplex titer. These are usually viral illnesses that can cause these. Okay. What other diagnostic tests should you obtain and why? What about an MRI? Would you do an MRI? I know you did a CT and your CT was negative. Remember, we just talked about CTs not being really good at looking at tissue. So would you do an MRI?
Yes. MRI might be indicated. Yes, to rule out.
Okay, beautiful. What else can we do for this patient? I went a little far. What other diagnostic tests? Believe it or not, a hemoglobin A1C is one of the most important things that you can do. It is very important for you to pick up on the fact that they're saying that she has diabetic nephropathy, one. She's diabetic with poor compliance. Okay? Diabetes mellitus is one of the most common things that give you a partial third nerve palsy. Believe it or not. So for this lady, a hemoglobin A1C is paramount. And yes, this does resolve when she gets her diabetes under control. Any questions there, guys? So the things that can cause them.
Real quickly, someone said check the eye pressure.
Okay, why would the eye pressure, what would be the reasoning for checking the eye pressure? Did they answer?
Yes, glaucoma.
Okay, so glaucoma would not necessarily give you a third nerve palsy. Remember that the third cranial nerve sits in the bottom of the brain. It actually comes through where the almost where that sphenoid bone is at the bottom of the brain, and it travels through that area there through the cavernous sinus. So anything that can press on those, the uncus of the temporal lobe that comes down can press on the third cranial nerve. You can get lesions along the third cranial nerve that can cause a ptosis. It can be affected like things like myasthenia gravis, diabetes. If there's trauma and there's bleeding into the brain, that can cause compression of the third cranial nerve and can give you that ptosis. A posterior communicating artery aneurysm, how it grows, can actually push on the third cranial nerve and give you a ptosis. Rupturing can give you a ptosis also. But glaucoma remember, it is essential. It's a problem in the eye. It's pressure in the eye. So it does not touch that third cranial nerve. Okay. Does that clear that up?
Yes, I think so. And then someone mentioned that head injury can be a cause, and I see it there on your list, trauma.
Yes, remember, bleeding into the brain, any trauma can cause compression of that third cranial nerve. You want to think third cranial nerve compression. Remember, we talked about where those cranial nerves are. We said that there are only two cranial nerves that are located in the cerebral hemisphere. That cranial nerve 1, which lays at the bottom of the brain, cranial nerve 2, which also is in the cerebral hemispheres. 3 and 4 are in the midbrain. 5, 6, 7, and 8 are in the pons. 9, 10, 11, and 12 are in the medulla. Okay, so you want to remember those. And so if you have an issue with the third cranial nerve, unless there's something compressing it or something along the myelin sheath that actually protects that cranial nerve, it should not disrupt the cranial nerve function. So if it's in the eye itself, the third cranial nerve does not run into the back of the eye. It actually innervates the eye, the pupil. So, I mean, if you knock out the complete eye, you can have some effects of the third cranial nerve, but remember, it just goes to the eye and innervates the eye. So, you have to have some kind of structural lesion compressing that third cranial nerve to give you a palsy in that respect. Okay? Any other questions, Laura?
I don't see anything. They're just saying thanks for the clarification.
Okay, awesome. Case number 5, 65-year-old presented to the emergency room following a motor vehicle crash. She was seated in the rear seat of the car and was not wearing a seatbelt. During the accident, she sustained significant head trauma. A neurological examination, she opens her eyes to deep pain. Now, I need you to be documenting your GCS as I call these out. And then you're going to tell me what her GCS is, okay? So she opens her eyes to deep pain. She is mumbling inappropriate words, and she moves her extremities to localize pain. What is her GCS?
Okay, 6.
No.
10. 7.
No.
10.
10.
4.
10.
10. Okay.
Yes. She opens her eyes to deep pain. That gives her a score of what, guys? Open to deep pain, give you a score of what?
Sorry, 2. They're answering 2.
Sorry, Laura. The problem is if I open the chat, then I can't see the question. So that's why Dr. Abuha has to help me.
No worry, I thought all the 2s were coming, and I was like, no, the GCS isn't 2, but it was actually answering your question. So
No.
sorry.
She's mumbling inappropriate words. Is what?
3. I'm getting a lot of 3s.
Okay. And she is, what was the last part? She moves her extremities to localize pain.
That's 5.
5.
Okay. So we counted, and she should be a GCS of 10. Correct? Okay. Yes.
Everyone's saying yes.
Okay. She intermittently holds her head up when she mumbles, and she's had 2 episodes of projectile vomiting since arriving to the emergency room. What is the significance of projectile vomiting, guys? Where's the vomit center?
Increase intracranial pressure.
Increase in
Concussion,
cranial
bleed.
pressure. Yes. But where's the vomit center in the brain? It's actually located in the medulla, which is in the brainstem. Okay? So if someone is projectile vomiting, you know that they have increased intracranial pressure and probably some brainstem herniation or brainstem dysfunction. Okay? She has some mild rhinorrhea. What is rhinorrhea? Anything with rhea at the end means CSF. So rhinorrhea, rhino, nose. Rhinorrhagia means that she's draining CSF and blood from her nose.
Yeah, they're all saying CSF from nose.
Yes. Rhinorrhagia is bleeding from nose, okay? Or she has no otorrhea, that means CSF from ear, but she does have some otorrhagia. That means CSF, that means blood coming out of the ear, okay? So remember, anything with rhea, rhagia, rhea is CSF, rhagia is blood, okay? What is battle sign? Battle
Sign of basal skull fracture.
Okay. It is a sign of basal skull fracture. It is bruising behind the ear, though. I don't want to diagnose it. I want you to tell me where it is. Bruising behind the ear. What is raccoon's eyes? That is periorbital ecchymosis. Okay? You know, if you know what a raccoon looks like, you know they always have these dark rings around their eyes. Okay? She hasn't had any seizures. She complained of double vision. Okay? And her field of gaze exam is below. I'm going to show you her field of gaze exam. What is that, guys? Which cranial nerve is being affected here?
6.
Correct. Okay? Remember, the lateral rectus muscle pulls the eye out. If the lateral rectus muscle is affected and it's weak, the eyes are gonna set in. So the eyes are gonna settle in. So she has bilateral abducens palsy. She has both of her 6 nerves, cranial nerves, have a palsy in them. Okay, so both of her eyes are rotated in. So it's a bilateral 6 nerve palsy. If this was a bilateral 3rd nerve palsy, what would that look like?
It would be facing outwards.
Yes, they'd be pulled outwards. Okay? If this was a bilateral trochlear palsy, what would it look like?
What? Oh.
Dr. Abuha abandoned
Yeah.
me.
Sorry, up and out.
Yes. I'm sorry, guys. Every time I try to maneuver this thing, it moves. All right? So remember, cranial nerve 6 moves the eye lateral. Cranial nerve 3 moves the eye medial. It also moves the eye up and in. It also moves the eye down and out. It also moves the eye up and out. Cranial nerve 4 moves the eye down and in. Okay, forward to the floor. Okay? And cranial nerve 3 also moves the eye medially. So medially, up and in, up and out, down and out, 3. Laterally, 6. Down and in, 3. Down and in, 4. I'm sorry. Okay? Remember that the muscle that's affected is going to have less power. So what's going to happen is the eye is going to rotate to the stronger muscle. That's why both of her eyes are rotating in, because the lateral rectus muscle is dysfunctional. So the medial rectus muscle, which pulls the eye in, is actually taking over. That's why both of her eyes are pulled in. Okay? So what could be going on with this young lady? Okay? What could be going on with her?
I'm not getting anything.
Okay. It's not rocket science. Whatever has happened has actually compressed the 6th cranial nerve. Okay? We said what her Roscoe-Como scale was, but whatever is going on is compressing her 6th cranial nerve. This was actually an actual case, and what had happened is basically she had a C1, C2 distraction injury that actually displaced her brainstem, and it caused a traction injury to the abducent nerves into the canal of dorsals. It's actually a canal at the base of the brain, close to the cavernous sinus, where the 6th cranial nerve comes through. Not that I expect you guys to know any of this, but that's just what had happened. It wasn't even an intracranial injury itself that caused this. It was actually a C1, C2 distraction that actually displaced the brainstem that actually caused this distraction of cranial nerve 6. Okay? And this happens a lot. You can see it. People come in with the bilateral obtusance palsy, whiplash, increase intracranial pressure, hangman's fracture. They usually don't survive, but if they do, they can have it. Halo traction can give it too, because it actually can displace the 6th cranial nerve entry into this. Any questions or comments on that? This is not a test part, please, guys. I just need you to know what the 6th cranial nerve palsy is. I just wanted to let you know what the case was so you can have an idea. Any questions, Laura?
Just someone asked if this is going to be posted, and it's posted in all 3 sections.
Okay, guys. So a 47-year-old African-American man walked into the emergency department complaining of right-sided facial numbness and weakness. He said that it started before bed the previous night. The patient noted that fluid dripped out the right side of his mouth while he was drinking. Now, it concerns me that he waited until the next morning to come to the emergency room, but that's okay. That happens. He then awakened in the morning to right-sided facial droop, inability to close his right eye, excessive tearing from the right eye, and hypersensitivity to sound on the right ear. Okay, guys, from your assessment skills, which cranial nerve is being affected here? Laura, are we getting any answers?
Yeah, 6 and 2 are the answers I've gotten.
No way. Who said 6 and 2? No, guys.
7, 8, 3, 7, 7, 8. Getting a lot of different answers.
7. 8, no. I know you said 8 because of the hypersensitivity with sound, but remember that parts of cranial nerve 7 can actually innervate that sound. It actually, when damaged, can cause hypersensitivity to sound. And I actually think I have it on your PowerPoint. So just take a look at that. Okay. What else? It can actually control a little bit of the lacrimal ducts, so you see a little bit of excessive tearing. But this is all cranial nerve 7. Okay.
Some people are asking
All
Bell's
cranial nerve
palsy.
7.
No.
Sorry.
Some people are asking Bell's palsy, question mark.
Okay. Why do you think it's Bell's palsy? Tell me. If you can put your mic on, that would be great. Somebody who wants to just put their mic on and tell me why they think Bell's palsy. Come on, guys. Shoot it out. Nobody? No takers?
I have a couple people that said flu-like symptoms, only upper part of his right side. He can't close his eye.
Okay. Well, his entire right face is affected. That's where your focus should be. I mean, he does not have just a lower part of his face. Now, if it was just the lower part of his face where he just had drooping of the lower part of his face, then that would probably be central. Okay, that's probably coming from the cerebral hemispheres. Now, if it's the entire right side of his face, then you want to think, okay, well, this sounds like it's peripheral, meaning that it's, remember, we have the central nervous system, which is the brain and the spinal cord, and then the peripheral nervous system, which is your spinal nerves and your cranial nerves. So this is something that is a peripheral issue. It's a cranial nerve issue, okay? So if you look at all the things that's going on here, there are right-sided facial numbness and weakness. He's dripping from the mouth, so the lower part of his face is affected. He has right-sided droop. He can't close his right eye. And usually, if it's a stroke, they can close their eye. It's just the lower part of the face. So I want you to think, if the entire cranial nerve 7 is affected, it's probably peripheral, and that's when you're going to be thinking Bell's palsy. Now, not to say that you can't have a total cranial nerve 7 palsy with a stroke. It usually is a brainstem stroke, and those are rare. But if you see this, especially with the fact that this guy has had this over a few days, and the other symptoms associated with it, it's probably something like a peripheral issue, which will be a Bell's palsy. So on review assistant, he's noted slight pain behind the eye. Okay, usually strokes don't give you pain behind the eye, so that's usually it. He denies any recent cold sores, ear discharge, or recent trauma. However, he's noted to have flu-like symptoms. So definitely these flu-like symptoms are what's implicated and could possibly be the reason for your 7 cranial nerve dysfunction. Okay. He has no previous medical history. However, he has not seen a doctor in 20 years. He denies any prior surgeries. He is a smoker, but denied alcohol or any illicit drug use. Okay. The point to this is I want to make sure that you understand the entire 7 cranial nerve is affected. It's usually peripheral. If it's the lower part of the face that's affected, it's usually central. So if I just have a droop of the face, and when I smile, I have a bend in the corner of my face, thinking at that point, when you look at that person, you're thinking central. This is probably coming from a stroke. Now, if they have a difficulty, they can't wrinkle their forehead, they can't close their eyes, they can't, they have tearing, they have the hypersensitivity to hearing. Sometimes they can have decreased taste on the back of their tongue. This cranial nerve 7 causes that. Excessive tearing, floaters. Sometimes they can have that diplopia associated with it. Usually this is peripheral, meaning it is affecting the 7 cranial nerve. It's not something compressing it. It's not a dysfunction of that part of the brain, but it's usually something with the myelin, okay, that can actually cause this cranial nerve disruption. Any questions, guys?
I forgot to mention, someone had a question. What were the answers for case study, the cases number 1 and number 2?
I do not know, and I'm not going to go back there yet. Remember, guys, this is recorded. So it's being recorded, and you can actually go back. I'm going to post the recording as soon as it's available, and you can go back and look at those.
Thanks.
Okay. On exam, the patient is in no acute distress, no obvious discomfort. He was hypertensive. On initial blood pressure is 182/108. His speech was slightly slurred, and that slurring of the speech is probably due to the facial weakness, not speech dysfunction. Okay, so this is not aphasia or any, this is a dysarthria, and that's a motor speech issue. Okay, so when it's dysarthria, is usually because of weakness that can cause the dysarthria. Okay. It also can be a cerebellar issue, but it's usually a motor issue. Okay. No nystagmus was noted. He demonstrated an inability to close his eyelid, as well as generalized weakness of his right face, including his forehead. His pupils are 3 millimeters, equal, round, and reactive. Something that you guys like to call perla, but you're not going to do that anymore after this class. You're going to say pupils are equal, round, and reactive. Okay. And his extraocular movements are intact. Now, his extraocular movements are cranial nerve 3, 4, and 6. And you want to move, the eyes should move smoothly through a letter H. I forgot to say that when we talked about the last case study. The eyes should move smoothly together through the letter H or a star when you're looking at extraocular movements, okay? And in that case, you're going to tell the person to look at your finger, follow your finger with your eyes, do not move the head, and they're going to follow the finger through that letter H, okay? So you're going to go down, up, down, or you can tell them to follow it through the star, okay? And we already went through what cranial nerves are where, okay? Whichever technique is more comfortable for you, you can use that. So we already said which cranial nerve closes the eye. We said cranial nerve 7. Which cranial nerve is involved in facial weakness? We said cranial nerve 7. From the symptoms, does the symptoms appear to be peripheral or central? We said it was the entire 7 cranial nerve that was affected, so we think that it's more peripheral than central. And what diagnostic test would you order and why? Now, if you think it's peripheral, you're still gonna scan the brain. Because remember I said, it could be a brainstem issue, okay? The 7 cranial nerve comes off of the brainstem, so it could be a brainstem stroke. They're very rare that will give you a complete cranial nerve 7 palsy, but it could be. So you're still gonna get an MRI of the brain to look at the brain structures to make sure that you don't have a stroke, okay? You can get blood tests. You can get lumbar punctures to look at cytology. You can also you can look for infections. All these things that you want to do. But Bell's palsy is usually transient. The less damage there is to cranial nerve 7, the faster the patient recovers. The more damage, the longer they take to recover. Bell's palsy can be recurrent. These patients, stress can exacerbate them, and they can end up just coming back in high stress episodes. So you can see this come back and forth. Okay. Any questions there?
I'm not sure if you said it, but they were saying CT of the brain.
Well, you can do a CT initially, but an MRI would be the most optimal test. Because you're suspecting that this is probably a stroke. You can rule out a CT to make sure that there's no blood. But in most cases, you're going to look at an MRI because that's more sensitive at looking at tissue. So you look at the MRI and see what's going on. Okay. So all diagnostic tests were essentially normal, including electrocardiogram and labs. You're going to look at your CBC. You want to look at your WBCs. You want to look at neutrophils, lymphocytes. Remember, if the patient has lymphocytosis, then you know it's some kind of viral issue. If they have neutrophilia, you know that there is probably some kind of bacterial issue, so you're going to look at those. MRI of the brain, you want to pay particular attention to the back structures of the brain because these can be brainstem. On this patient, he has vascular tortuosity, which means that he has long-standing hypertension. Usually you'll see that. Okay. Any other questions, Laura? Laura? Okay. Let me pull it down.
Sorry, I stepped away for a second.
No, that's fine.
Just getting a snack.
All right. Sorry. Okay. 67-year-old woman is brought into the ED after being struck by a car while crossing a main street. On arrival to the ED, her eyes remain closed to stimulus. She makes no verbal sound and flexes her arms towards her body with deep, painful stimulus. Her BP is 200/60. Heart rate is 55 beats per minute. Respiratory rate is 6 beats per minute. As you open her eyelids, you notice that her right pupil is 8 millimeters non-reactive, and her left is 4 millimeters and minimally reactive. When you move the patient's head to the left, her eyes move upwards her eyes move up towards the right, and when you move her head to the right, her eyes moves towards the left. Okay, so that's a whole lot in that one scenario. Okay, so she makes no verbal sound. She doesn't open her eyes. There's no verbal sounds. And she flexes her arms towards her body to deep, painful stimulus. What is her GCS?
5. Decorticate posturing.
She gets 1 for
5.
verbal. She gets a 1 for eye opening, and she gets 3 for deep, painful stimulus. When on deep, painful stimulus, is she or extending? She is flexing.
Yeah, flexing.
Is flexing considered decorticate or decerebrate?
Decorticate.
Decorticate posturing. Okay. So decorticate to the core. Decerebrate, they're extending and pushing their legs out. Okay. So you have decorticate posturing to the core, decerebrate posturing, they're extending. Okay. Now, what does decorticate posturing mean? We said that we had a GCS of 5, and our patient is decorticate posturing. What is Okay, brainstem intact. Okay, her cerebral hemispheres are dead.
Mm-hmm.
Yes. So if you have a patient who is decorticating, that means that the cortex is probably dead, but the brainstem is probably functioning. Now, we did some brainstem testing there. And tell me, I see everybody putting it in already. Brainstem testing is, we did oculocephalic. So on doll's eye, is her doll's eye positive or negative? I see a whole lot of positives. Yes. She has positive doll's eyes. Is a positive doll's eye a good thing or a bad thing? Good. Yes. You see it coming out. Yes. A positive doll's eye is a good thing. You want a positive positive Dahl's eye. You do not want a negative Dahl's eye. If you have a negative Dahl's eye, that means that you do not have brainstem functioning. Okay? You can do your co-caloric testing. Okay? Usually you don't do just one, you do both. So you'll do Dahl's eye, and then you'll do co-caloric. But if I do the Dahl's eye and her Dahl's eye is positive, do I necessarily have to do co-caloric? Probably not, because I already know that her brainstem is functioning just based on her Dahl's eyes. So if I have positive Dahl's eyes, I don't want to go stick cold water in her ear, because that is very, very, very irritating. Now, what does our vital signs say to us?
Bad.
She needs neurosurgery. Come on, guys. Bad. Yes, true. She has a widening pulse pressure. She has bradycardia. Yes, my love. Cushing's triad. Widening pulse pressure, bradycardia, and apnea. Yeah, she's like slowly breathing or barely breathing. She's bradycardic, and she has a widening pulse pressure. What does Cushing triad indicate? That she's about to herniate. Oh, she's already herniated, because some structures of her brain is herniating. If you look at her pupillary size, her right pupil is 8 millimeters. What does that mean? It means that the uncus of the temporal lobe is actually pushing down on the third cranial nerve, and it's actually stopping it. And that's why the third cranial nerve is being compressed by the uncus of the temporal lobe. Okay? So that's uncal herniation. So she already has uncal herniation. Okay? Now, so we have a G6 of 5, we have decodicate posturing, and we have a positive Dahl's eyes. Yes, she needs some kind of intervention fast. Okay? Look for a family if she can be DNR. She's only 67, guys. She had a motor vehicle accident. She probably has blood in her head. Maybe we can decompress it. Okay? Maybe we can definitely decompress it and give her a chance. Okay? We can give her mannitol. We can give her, what else can we do? We can also, yes, we can do a craniectomy. We can also do mannitol. We can do hyperventilation. Okay? Hyperventilation. What does hyperventilation do? The one thing I see here is steroids. No, we won't do steroids in this case, because most likely what's going on in this patient is she has cytotoxic edema. Cytotoxic versus vasogenic edema respond differently to steroids. I mean, at this point, we'll probably throw everything but the kitchen sink on her. But, you know, if you're going to, in this case, you're probably going to do hypertonic solution. Now, when we talk about this patient, we need to decompress, decrease her intracranial pressure. How are we going to decrease her intracranial pressure before neurosurgery takes her to the OR? Is we're going to hyperventilate her. How do we, what does hyperventilating her do? Hyperventilating her will blow off CO2. Remember from your patho class, CO2 is a potent vasoconstrictor and a potent vasodilator. So high levels of CO2 will cause vasodilation. Low levels of CO2 will cause vasoconstriction. So if you're going to blow off CO2, you're going to lower the CO2 levels, which is going to cause vasoconstriction. Remember, the Monroe-Kelly doctrine says that only 3 things live in the brain: blood, CSF, and brain tissue. If one increase, one has to decrease in order to increase to maintain homeostasis. So blowing off the CO2 will decrease the amount of blood in the vasculature in the brain, which will help to facilitate time. The 3% of the mannitol will decrease cerebral edema, which will give us time. And then she'll probably have to go to the OR, depending on what's going on. All right? Good answers, guys.
How do you hyperventilate with this GSS?
So we said patient's G6 was 5. We said that this was indicative that she had brainstem function, but her cerebral hemispheres were dysfunctional. Which cranial nerve dysfunction is manifested here? Cranial nerve 3 was being compressed. What are the significance of the vital signs Cushing's triad? Is your oculocephalic reflex positive or negative? We said it was positive. And is the patient flexor extensor posturing? And we said flexor posturing. All right. Yes, we're going to intubate the patient. We're
Guys,
probably going to take
you
her to
need
your.
to watch, Sarah.
Any
You
questions
watch
on
after
that, guys?
yourself, okay?
Yeah, I've been doing that.
If you're saving food, put it in a bowl and put it in the fridge, and then you wash your pan.
Okay.
Well, if we're hyperventilating, probably we're going to intubate by then.
Okay. That's what I thought.
Did I miss anything, Dr. Albuha?
No, it looks like they were discussing on their own, but yeah, you definitely have to intubate in what you just said. So, and that's how we'd hyperventilate them. Correct?
Yep. Well, you can do it with the venti mask too. I mean, you can do it with the ambu bag. I'm sorry. You can always ambu them and hyperventilate them that way. But yeah, you're gonna try and intubate them as soon as possible. All right, guys. We're getting there. We're getting there.
Intubation or embo bag.
This is case number 8.
8.
Tim is a 30-year-old man who was found on the ground next to his car after it hit a cable pole on the side of the road. Witnesses state that the man got out of his car and was able to walk a few steps after the collision, but then collapsed within a few minutes. Paramedics subsequently found the man unconscious on the side of the road. He was taken to the nearest trauma center. His vital signs, 185/92, heart rate is 63 beats per minute, temperature was 99, respiration says 12. O2 saturation was 97%. Physical exam revealed a right-sided fixed and dilated pupil.
That's your period of lucidity. You better run. He's bleeding in his brain.
Oh, Kim, please. They know
so
you
he had
like to do that.
lucid interval. So we look. We did a CT of the brain, and this is what we saw on that CT. Now, guys,
Sebastian,
remember
I'm gonna
that
text you guys, you and Jonas,
from your lecture,
because you have class starting back on Monday.
I showed
and they
you
sent
what
you,
a
that you
subdural
have to do
hematoma looked
virtual.
like, and I showed you
So
what
each
an
one of you gonna
epidural
have to get a
hematoma looked
computer
like.
to go
One thing
online
I'm going
for
to ask
class.
you with this one is this person
It's just like the one that I'm
bleeding into the
having
brain
now.
parenchyma, or are they bleeding into the meninges? Remember, we have the meninges of the brain. So we have the dura, which is the outermost layer. We have the arachnoid, which is below, and then we have the
epi.
pia mater. Okay? Above the dura is the epidural space. Below the dura is the subdural space. Below the arachnoid is
What?
the subarachnoid space.
Oh.
The epidural area has over in the temporal lobe region has the middle meningeal artery that goes up into the epidural space and provides arterial blood flow in that area. So the middle meningeal artery is what's in the epidural space. In your subdural space, you have, hold on one second, my computer's about to die. That wouldn't be good.
Oh my God, are we gonna get a break? My buttocks are hurting.
Okay. So in the subdural space, you have bridging cortical veins. And you have the venous sinuses, which are venous flow from the brain. So that's how the venous blood gets from the brain back into the heart, okay, through the venous sinuses. So in your epidural space, you have the meningeal artery. Subdural space, you have the bridging cortical veins, okay? Those are very important. In the subarachnoid space, you have the arachnoid villi. These are good, important structures that I want you to remember when we're talking about bleeding into the brain. This bleed right here is a convex type bleed. And judging from the appearance of how this patient was, this is likely an epidural hematoma. And the key to discerning that is that lucid interval that he had. He crashed, and he was able to get up. He might have lost consciousness initially, then he was able to get up, walk a little bit, was awake when the witnesses saw him, and then completely out by the time the paramedics get there. Remember that an epidural hematoma is an arterial bleed. There's a rapid collection of blood in the epidural space that shifts the brain structures, and initially the brain is able to accommodate that. So that's why they have that lucid interval. Brain says, let me move over a little bit, move over here, and just make space for this blood. But then it starts coming in at such a rapid state that the brain can't move over anymore. Because remember, the skull is a fixed blocks. The brain can't move over anymore. What usually happens is that you end up with brainstem herniation. Okay? So this is an epidural hematoma. This is a convex shape. Look at this, it's convex. If it was a subdural hematoma, they look a little bit more sickle. So it looks more like an S. So it'll go like this. You see it like this, and it's more. Subdural hematomas are more slow bleeds. So usually patients look a lot better. They don't rapidly decline. If they're younger and they have a large subdural bleed, yes, they can rapidly decline. But older patients can actually accommodate blood in their brain for a while before you see them start being symptomatic. Sometimes when you see an elderly person with a subdural hematoma, you look at them and you're looking at their scan and you're going, something doesn't fit here. That's because as we age, our brain shrinks. And what usually happens with those bridging cortical veins, remember the dura gets stick to the skull. And then those bridging cortical veins, they get taut. So that's why some older people that come in with this subdural hematoma and they go, well, I didn't hit my head, I didn't fall. But just a little jawing of the head can actually tear those bridging cortical veins and they end up with the subdural hematoma. Okay? In this case, this guy has this lucid interval. You have this CT here that gives you this convex shape. It's usually over the temporal lobe that you see this, and this is an epidural hematoma. Okay? Epidural hematomas are dangerous. They need to be dealt with emergently, or as patients do really bad. Okay? So any questions, guys?
No questions that I see.
Okay.
Oh, someone asked for treatment.
Treatment will be surgery. They'll have to have a craniotomy and evacuation of that subdural hematoma, that epidural hematoma. That's the only treatment. Okay. Small epidural hematomas we tend to leave because remember the body takes care of blood when it's in a cavity where it's not supposed to be. The body does take care of it. But epidural hematomas that cause brainstem compression or cause brain compression, they have to be evacuated. There's no other way to deal with them. So surgery is going to be indicated. Okay? So my questions for you was, is this an intracerebral or extracerebral bleed? Intracerebral means in the brain parenchyma. Extracerebral means outside of the brain parenchyma, but in the skull. His bleed was in his meninges, so it's not intracerebral, it's an extracerebral brain bleed, okay? What type of bleed is this? Is it venous arterial? We said it was arterial. What does a fixed dilated pupil mean? It means that this patient has some uncus herniation. That means the cranial nerve number 3 cannot innervate the pupil and it cannot cause the pupil constriction, so it's being compressed. Okay. And how would you treat this patient? Of course, you need a stat neurosurgery consult.
Extra arterial.
All right.
And craniotomy. Oh yeah, my buttocks! I can't. I need a break.
Make sure that this thing is still recording because the recording was in my way.
I am recording.
Are they live?
What?
Is your teacher live?
Yeah.
And you're talking all this mess?
No.
We
mute. They asked us to
just
mute.
Hit the recording thing, and I want to make sure that it's still recording.
We mute our.
Laura, can you tell if it's still recording?
It looks like it is.
Okay, good.
I am recording. It's gonna be
All
on
right.
YouTube.
29-year-old male brought to the emergency department after a head-on collision with another car. The patient was not wearing a seatbelt upon presentation. His blood pressure is 135/65, heart rate is 112 beats per minute, respiratory rate is 18 beats per minute, oxygen saturation is 100% on mask. His eyes are closed, but opens to speech. He can move his arms and legs on command. When you ask him a question, he's disoriented but able to converse. What is his GCS score?
Oh God, 13.
I'm getting 12.
Okay, why 12?
Wouldn't it be 13?
I think it's 13.
It would be.
Yeah, it's 13. Yay, I got
He
it.
only loses 1 point for confusion.
For confusion, yeah.
Okay, he
It's
follows
13.
commands readily, and
It's just that
the only thing he loses he opens his
his
eyes
eyes.
continuously.
Yeah.
He should be a 13.
13, yeah.
Right?
I'm dead.
Huh?
No, I'm talking. Talking to Roy.
Oh.
I was gonna say who texted you, but it was my phone.
All right,
I just got a notification.
Laura, anything there?
Text alarm went off, and I was gonna be like, "Oh, you're probably who's texting you?"
Laura?
It was my phone.
Laura!
No, nothing. Everything's
I thought
good.
it was your phone. I
Okay,
didn't
good.
know it was my phone.
Sandra is a 59-year-old woman with a past medical history of hypertension, hypercholesterolemia, diabetes type 1. Alcohol abuse is brought to the emergency room by her daughter, who states that her mom has been acting funny, open quotations, close quotations, over the past hour. She states that the patient did not know where she was despite being in her own house. She also did not recognize her family and was speaking incomprehensibly. Her blood pressure is 150/80. Heart rate is 90 beats per minute. Temperature is 98.9. Her respiratory rate is 16 beats per minute. On physical examination, she is diaphoretic, agitated, tremulous. Echocardiogram is sinus rhythm with normal ST segment in T waves. Which of the following is the most appropriate course of action for this patient and why?
A lot of people are putting in check her blood sugar.
Okay, why?
Because hypoglycemia can mimic stroke.
Guys, it is the exact answer. The blood finger stick is first. You're going to do that anyways before you take it to the CT scanner, because the only thing that can prevent you from giving a patient TPA is not having a blood glucose. Every patient that's a candidate for TPA has to have a finger stick first. So in these kind of cases, you need to make sure that you assess the blood glucose. Really good. I've caught a lot of students on that one, so good job, guys. All right. 54-year-old man is brought to the ED by his wife for bizarre behavior. The wife complains that her husband has not been acting like his usual self over the last several days. He's been crying inappropriately for the past 2 weeks, and over the past month, he's gone from being a model employee to not showing up for work, not turning in his reports, not going to the gym, and worst of all, he has not showered or changed his clothes in the past 3 days. She recalls that her husband complained of morning headaches for the past 2 months. The patient is otherwise in good health and does not take any medications. His BP is 135/87. Heart rate is 76 beats per minute. Temperature is 98.9. Respiratory rate is 14. His examination is otherwise unremarkable. So, based on the presentation, which part of the brain is being affected, guys?
Frontal.
The frontal lobe.
Okay, Kim,
It
you have to put your mic
would
on.
be the frontal lobe. Remember, frontal lobe is
Executive.
learned social behavior, It is mood and affect, all housed in the frontal lobe. Okay. All your executive function, what you think is appropriate and what you don't think is appropriate is all housed in the frontal lobe. So definitely the frontal lobe. How would you work this patient up?
MRI.
You definitely do MRI. You can do CT of the brain. You do that.
Well, the headaches might be a bleed, but if it's been on for a while, it might be a tumor also.
It might be. However, you're going to do the CT first, plain, rule that out, or you can actually go straight to the MRI. Okay. How would you work this patient? What is the significance of the headache occurring in the morning?
Would it have to do with the position of laying down in bed?
Yes, but why?
Sleep apnea, lack of oxygen.
No, not sleep apnea, but yes, increased intracranial pressure. When you're in a supine position, your brain contents can actually, the CSF is not flowing down. So you have more CSF, more blood. So you end up with more intracranial contents. When you're in an upright position, you can actually have gravity helping a little bit. So laying in a supine position, people who have morning headaches, you should be suspicious for increased intracranial pressure. Usually what happens is they're laying flat, everything is like stable at night, and in the morning they get up, they have this really bad headache. As they go through the day, the headache gets a little bit better, okay? But morning headaches, you should always be questioning for increased intracranial pressure. Any questions on that, guys? Nope. Nothing, Laura?
Someone just asked, is that why patients are at a 30-degree angle in the hospital?
Yes, it is. We always put the head of bed on a patient who comes in with a stroke, any patient who comes in with cerebral edema, any patient who comes in with an intracranial bleed. If you see, when I go to the emergency room, they have the patient flat for intubating. The first thing I do is I raise the head of the bed. Okay, you always raise the head of the bed. You go under a 30-degree angle, facilitate flow, stop the flow of blood to decrease intracranial pressure. Okay. All right, case number 12. 25-year-old female with complaints of weakness in bilateral lower extremities has been gradual over the past 5 days. She denies any medical history. She reports has not traveled outside of the country in her life. Denies smoking, alcohol, occasionally. She does admit to having the flu about 2.5 weeks ago. These are her vital signs: temperature 98.4, heart rate 78, respiratory rate 18, blood pressure is 105/45. And look at her labs: free hemoglobin 13.1, hematocrit 38, WBC is 10, platelet count is 300. The neurologist does a lumbar puncture and it shows elevated protein and normal white blood cell count in CSF. Now, when we're looking at CSF, it's very important because this is another diagnostic feature that is very important when you're dealing with brain patients. You want to evaluate CSF. When you're evaluating CSF, you're looking for white blood cell count. If it's elevated, you want to look at red blood cells. If you see red blood cells, it could be a traumatic tap. So you want to look at that. And if you see red blood cells and you're suspecting a traumatic tap, you're going to ask the lab to spin it down, especially if you're looking for something like a subarachnoid hemorrhage. You're going to ask the lab to spin it down, and you're going to be looking for something called xanthochromia. Xanthochromia is a spin down, it's a byproduct of blood that occurs in patients who've had subarachnoid hemorrhages. So someone comes in and they're complaining of the worst headache of their life, and you do a CT scan and then you don't see any blood. You don't say, well, okay, you don't have an aneurysm, you don't have a subarachnoid hemorrhage, I'm send you home. The appropriate thing to do in that patient is to do a lumbar puncture and look for what we call xanthochromia. And that's the byproduct of blood breakdown that's going to occur. And remember, sometimes patients have a small bleed in the brain. They don't come to the ER right away, but then that headache doesn't go away in 2-3 days. You scan them, you don't see the blood because the body already took care of it, but the CSF will still have that blood. And when you spin it down, you'll have xanthochromia. And next thing you want to look for in the CSF, we said we want to look at white blood cells. We want to look at red blood cells. We want to look for xanthochromia. We want to look at protein. Protein will tell us if there is any protein should be like 0. So if you have elevated protein, it can be infectious. It can be inflammatory. So you want to look at protein. You also want to look at glucose. Glucose that is normal doesn't indicate that there would be an infectious process. Usually what happens is the bacteria eats the glucose. So if there's a bacterial meningitis, what would happen is that the glucose will be low and the protein will be high, okay? If you have a patient who has elevated WBCs, elevated protein, and low glucose, in that person, you're thinking that this is probably a meningitis, a bacterial meningitis. But you want to look also at the lymphocytes and the neutrophils. If the patient has a viral meningitis, or it would be lymphocytosis. If they have a bacterial meningitis, it will be neutrophilia. So you'll have elevated neutrophils, elevated white count, elevated proteins, and low glucose for bacterial meningitis. Viral meningitis, the protein will be elevated, but not as elevated as bacterial. The white blood cells will be elevated, but you'll have lymphocytosis, not neutrophilia. And usually glucose can be down or just normal, okay? Depending. Now, in this case, you have a patient with elevated protein with normal WBCs in the CSF. That usually indicates that there's some kind of inflammatory process going on. Because if there's no white blood cell count, that means that there's no bacteria, there's no viral issue, there's no bacterial issue. Why is the protein elevated if there's no bacteria or viruses in the CSF? It usually means that there's an inflammatory process. So when you're looking at lumbar punctures, you have to look at all these things to try to deduce what's going on with the patient. Of course, you're going to put it with the patient's symptoms. And this patient was having weakness, bilateral. So we know probably there's an inflammatory issue going on. But you want to analyze the CSF completely to make sure that you can actually diagnose what's going on with the patient. Okay. Laura, is anything else?
Someone was asking if you could repeat the difference between bacterial and viral meningitis.
Bacterial, usually you have a neutrophilia. So you'll have elevated neutrophils. You will also have elevated white blood cells. You have elevated protein and low glucose. Okay. Viral, the WBCs will be elevated. You have lymphocytosis, so elevated lymphocytes. You have elevated protein, but it's not as elevated as bacterial. Glucose, there's no bacteria to eat the glucose, so glucose is usually normal. It could be a little bit low, but it's not as in bacterial meningitis. Any other questions, Laura?
Nope, that's it. Thank you.
I'm sorry, Laura. I appreciate you.
It's no big deal.
MRI of the brain in this patient. This is a normal MRI scan. You see the soul size of the brain. This dark is brain tissue. The white is CSF. This is probably a T2 image. And when you go into your clinical course and you start reading scans, we'll explain this a little bit more to you. I'm not going to belabor you with it here, but this is a normal MRI. This is a T2 image, and this is a sagittal cut. Sagittal, back and forth, right to left. Don't worry about it. Are there any diagnostic tests that you would perform prior to getting a lumbar puncture on a patient? If so, why? Let me see, Laura.
Okay, they're saying brain CT to rule out bleed.
The brain CT part is correct, but it's not to rule out bleed, but you're looking for edema. Okay? Because if someone has significant edema in the brain and you go stick a needle in their back, what you're doing is you're creating a negative pressure. So you're going to reduce CSF, you're going to create a negative pressure, and you can cause that patient to herniate. So you will do a CT of the brain. That CT of the brain is to rule out if there is any cerebral edema. Okay? Someone with significant cerebral edema, you want to hesitate at doing that lumbar puncture, because you can actually cause the brain, the structures of the brain to herniate. What's striking about the vital signs in lab? We talked about those. What pertinent information did you get from the history? The fact that he had the flu shortly before would be indicative. Anything else, Laura?
No questions here.
All right. Guys, do you have any other questions? Do you need any clarification on the CSF? That whole thing was just to introduce how to analyze the CSF. Remember, if you have a subarachnoid hemorrhage, someone comes in with the worst headache of their life, depending on how long ago that headache started, you may see a negative CT of the brain. If you see a negative CT of the brain and everything leads to subarachnoid hemorrhage, you don't say, okay, well, we're done. You have to do a lumbar puncture. And when you do that lumbar puncture, you're going to look for what we call xanthochromia. Xanthochromia is a byproduct of blood breakdown in the CSF. And that's very important for you to remember. All right? All right, guys?
Yep.
All right. Case 13, 57-year-old African-American male presents to the ED with right-sided weakness. Dizziness started an hour ago. Temperature 8.7 as a heart rate. Respiratory rate is 16 as BP is 225/110. These are all my ER nurses who are going to jump at this one. They see these like every day. Okay. Hemoglobin 11, hematocrit 33, WBC 7.3, platelet count is 75. Sodium is 140, potassium is 3.7, BUN is 18, creatinine 1.35, glucose is 90. Past medical history is hypertension, normally controlled with 2 agents, obesity, hypercholesterolemia, and he's currently on a statin. What's striking about the vital signs and labs, guys? What are the 2 things you're picking out from the vital signs and labs?
The blood pressure and the platelets.
Blood pressure and platelets. Perfect. Yes. You have a low platelet and your blood pressure is significantly high. He's African American, hypertension, comes in with significant hypertension, low platelets. What are your first thing that you're thinking? This patient probably have a bleed. Okay. What type of test would you order? We said we need to get it fast. So definitely we're going to get a CT of the brain. What's striking? We talked about the vital signs, the blood pressure and the platelets. What stands out in the labs? We talked about the platelets, I'm sorry. And what treatment plan for the patient depends on what's going on. He does have a bleed. He may need, blood pressure actually needs to be reduced before we do anything else. And then we probably have to consult the neurosurgical team to see what the treatment is. Yes, Ardeen for sure.
Can I ask you a quick question? Someone was asking earlier the word that you are looking for, I think, in meningitis. I have to scroll up. The
Meningitis?
yes.
Xanthochromia?
Meningitis. It starts with a Z, an X or a Z.
Oh, no. That's not meningitis. That's subarachnoid hemorrhage, and that's xanthochromia.
Oh, that, okay, sorry. I couldn't remember what they were talking about. Okay, thank you.
Xanthochromia. Okay. All right, guys. Dr. DK is a 59-year-old physician who visits his brother, also a physician, while vacationing one summer in San Diego. Says, my wife told me that the clinical manifestations are subtle at first, but are becoming more disturbing lately. The last time I had an episode, I would have fallen down a flight of stairs if she hadn't caught hold of me. She tells me that during one of these things, I do not respond to anything, but I don't lose consciousness either. She says that I just stare into space and fidget with my tie or button. I don't respond to my surroundings, and I don't seem to know what is going on at all.
That's an
that
absence
I'm not
seizure.
in the present. It has been going on for about 3 weeks. In the last episode, last 3 or 4 minutes every time. At first, it was like 3 days.
It's
now
not partial
every other
seizure,
day.
it's absence
When I come out of it,
seizure.
I'm extremely confused, unable to speak clearly for some time. I try to talk,
Oh, hold on.
but apparently my words are incoherent. I remember very little about the attacks. I do not remember several things. However, the taste of what seems like soap in my mouth, and some mild stomach discomfort immediately before I black out. And when I become aware again, I feel a distinct sense of loss of time. And sometimes I feel so exhausted that I need a nap. I guess it's good because I've not had a grand mal yet, but it could be just around the corner. Now, we all know that this person's probably having a seizures.
Yeah.
That thing that he says he plays with his buttons and he plays with his tie. What are those called? Those are called automatisms.
Automatisms.
Okay? The smell that he gets
That's an
and
aura.
the taste of soap in his mouth, those are prodromes. Okay? And
What
the
did you
feeling
say,
of
Sebastian?
tiredness and confusion after is a post-ictal
Come here a
episode.
second. Come here a second.
Okay? Now, his type of
Where are you
seizure
going?
is
The bus
localized.
Close,
Okay.
close this that you open.
We have different types of seizures. We have simple, partial, which means that they are awake, but let's say they have a lesion in the left posterior frontal lobe, and this is what they're doing. They can't stop themselves from doing that. They keep doing that, and they can't stop themselves. But they're awake, and they're looking at their hand, and they're going, why am I doing this? And they're totally awake. That's a simple partial seizure, okay?
Yeah.
What this guy is having is a complex partial seizure because his eyes are open, but he's not aware of his surroundings, okay? They can walk during these episodes, they can perform different tasks, but they can't hear or interact with the environment. That's a complex partial seizure, okay? It's not an absence seizure. An absence seizure, usually what happens is they zone out and they zone back in. And a complex partial seizure is only part of the brain that's affected. An absence seizure, the entire hemisphere, the entire brain is shut down.